Hello, welcome to another of our digital sign-out sessions with surgical pathology and digital slides, a courtesy of the Digital Anatomic Pathology Academy and PATH presenter. Our case today comes from the realm of gynecologic pathology, and the patient is a fairly young person who has noted a polypoid mass about midway into her vaginal introitus. Fairly large size and otherwise painless and asymptomatic, not bleeding, ulcerated, or rapidly enlarging, but certainly bothersome. And so further evaluation of this mass seemed to indicate that it was polypoid, fairly circumscribed, did not appear to have any deep component to it. And so the lesion was excised, showing a spindle cell neoplasm, which we'll look at the slide in just a minute. But I thought it might be first interesting to consider what some of the spindle cell lesions are of the vulvovaginal area. This is a challenging area sometimes because things can be both deceptively bland and yet aggressive, as in the case of aggressive angiomyxoma, and even deceptively bland and be malignant, as in the case of low-grade fibromyxoid sarcoma, which, though uncommon in this location, does occasionally occur. And some lesions are just completely altogether benign, such as the fibroepithelial stromal polyps, which also occur in this area. Other lesions, neurofibromas, smooth muscle tumors, and so forth, can occur in this location, usually a little bit more readily identified and more characteristic of the histology that we would think of. If we look here at the histologic section, we can see that this is a lesion that is slightly distending the surface epithelium. There's no defined Grund zone or separation between tumor and the surface. And we have a variable vascular lesion of some dilated larger vessels and some smaller vessels. As we come into higher magnification, we can see that there are a few clusters of cells, a few more cellular areas, but generally these are fairly thin-walled areas, the vessels, and the cells have a quite uniform and relatively bland appearance. As you can see, there's a very delicate, slightly loose and myxoid change, and the nuclei are all quite bland, not really spindly, but slightly stellate perhaps. And there's this delicate collagen matrix that you can see here along with the high magnification here. So immunohistochemical staining was done and showed that some of these cells were positive with SMA, but they were negative with Desmond. They were ER/PR positive, and many of them showed CD34 positivity. And we mentioned the need to consider the relationship to the skin, and as you can see, there is a very graded response here between the mucosa and the commencement of the lesion, which is not sharply defined, as you might expect with, say, a perineurioma or neurofibromatous type of lesion, or smooth muscle or other type of lesion of that sort. We don't have very much hyalinization of the vasculature. There is a little bit of that, but it's really quite bland. So I think our differential here comes down to the aggressive angiomyxoma and the cellular angiofibroma. S100 staining was negative, excluding most of our neural tumors on that basis. So we also did an HGMA2, which was negative. So with that basis, we arrived at the diagnosis of cellular angiofibroma. Now, this is a lesion that is not very commonly encountered. It does occur in both men and women, generally in the anogenital or inguinal anal area of the body. Occasionally, these can be seen in other locations in the head and neck, although there is some overlap with spindle cell lipoma, which occurs more commonly in those locations. And we'll talk about that in a second. Usually this is occurring in the subcutaneous tissue or the submucosa. Occasionally it involves the dermis. And women tend to be a little bit younger when this presents, although our patient was even younger than this. As I've indicated, these are usually CD34 positive and hormone receptor positive, although that can be quite variable. They're negative for MUC4, for Desmond, S100, CD117, MDM2, other things that might be considered in the differential diagnosis. When you look under the microscope, as we've just done, you have these very bland spindle cells, a somewhat vascular stroma, often edematous, and occasionally you can encounter multinucleate cells, such as you might see with fibroepithelial stromal polyp. A few cases have been reported with higher mitotic rates, but these are generally not very highly mitotically active and certainly no atypical mitoses. Hyalinization of the vasculature is a common feature that we did not see in ours. Now, when these have been subjected to molecular and genetic study, it's been noted that there's a loss of RB1 and ROXO1, very similar to spindle cell lipoma. Additionally, some of these lesions may have TP53 mutations. Should you be inclined to do a P53 stain, don't be surprised if you end up with an overexpression or mutated pattern. So just to consider a little bit further the differential, as we've mentioned, aggressive angiomyxoma is in that differential, as these can be fairly similar, certainly similar location. Angiomyxoma tends to have a little deeper and more aggressive appearance in terms of deep spread, and additionally will be HMGA2 positive on immunohistochemistry. Low-grade fibromyxoid sarcoma, should that be in your differential, will usually be MUC4 positive. And these other entities also have individual staining characteristics that might help you to distinguish those two entities. So our final sign-out diagnosis is not Mullerian adenosarcoma, excuse me, it is cellular angiofibroma. I didn't edit my slide here. That has certainly a very good and favorable prognosis. Well, we hope you enjoyed that program. We look forward to your comments and feedback, and we'll look forward to having you on a program again soon. As always, please subscribe so you don't miss future releases of new videos. And if you like this, we certainly hope that you will share it with others. It's such a pleasure to do these, and we hope that they're useful to you. And we welcome your feedback directly or comments. And so until next time, thanks so much for joining me.